Good afternoon to all of our colleagues. My name is Hernandez Mondragon, Chief of Endoscopy Department of the Specialties Hospital, Centro Médico Nacional Siglo XXI in Mexico City, Mexico. And this is my colleague, Dr. Raul Antonio Zamarripa Mottu, therapeutic endoscopist, and we would like to thank Gastrointestinal Endoscopy Journal for allowing us to discuss the results of our recent paper entitled Clinical Feasibility of a New Antireflux Ablation Therapy, ARAT, on gastroesophageal reflux disease.
What is the reason that motivated you to carry out this clinical trial?
Okay, Raul, as you know, gastroesophageal reflux disease is a highly prevalent condition that affects worldwide population, involving all age groups and both genders. Diagnosis is based on clinical history, endoscopic assessment, and ambulatory pH monitoring. The main objective of treatment is to avoid early, mid, and long-term complications such as esophageal strictures, Barrett's esophagus, and esophageal adenocarcinoma. Treatment is complicated because there is no universal treatment for all patients, and not all patients can fit a specific treatment. Therefore, new treatments are needed in order to include more patients and avoid these complications.
What do you think of PPI and surgical treatment in patients with gastroesophageal reflux disease?
Proton pump inhibitors represent the cornerstone of treatment in most of the cases. However, up to 30% of them have partial symptom relief, particularly in respect of regurgitation. Moreover, besides PPI are capable of neutralizing the esophageal gastric acid exposure. The lower esophageal sphincter anatomy is not affected. Moreover, different studies have raised concerns about the potential consequences of long-term PPI therapy. Therefore, the cornerstone of management of PPI refractory GERD patients has been surgical laparoscopic fundoplication. However, its invasive nature and potential adverse events have raised concerns in patients and physicians.
What are the advantages and disadvantages of endoscopic treatment for gastroesophageal reflux disease?
Okay, endoscopic treatment has been an attractive option because of its minimal invasive nature, and different anti-reflux endoscopic devices have appeared, such as radiofrequency ablation, transoral incisionless fundoplication, endoscopic full-thickness application, among others. All of them have shown an improvement in quality of life in more than 70% of cases in early and mid-term evaluations, and allow PPI to be discontinued in more than 80% of patients. Moreover, there is a decrease in between 30 to 70% of objective measures of acid reflux exposure. However, their use is limited because of serious adverse events in up to 2% of cases, high cost, and the need of special equipment, limiting their widespread use.
Mucosal treatments nowadays are in constant development. Tell us about this new endoscopic therapeutic option and what is the pathophysiological mechanism by which patients with gastroesophageal reflux disease could benefit.
Okay, endoscopic mucosal ablation resection techniques are based on a scar formation at the esophagogastric junction level. They include several techniques such as endoscopic mucosal resection, endoscopic submucosal dissection, band ligation, among other modalities. The initial results were promising, and this is the reason why we proposed a new method of mucosal ablation that we named antireflux ablation therapy, or ARAT, in which we performed a controlled mucosal ablation at esophagogastric junction in order to promote a controlled scar formation with the use of hybrid argon plasma coagulation therapy. In this paper, we evaluated the clinical efficacy and safety of this technique, and we present the early and mid-term results in a cohort of patients with refractory GERD.
Tell us how your clinical trial was carried out and what were the main results.
Okay, in brief, we included 108 refractory GERD patients without sliding hiatal hernia between January 2016 and October 2019. ARAT technique was performed in all cases without complications, being male gender in 56% of them, with a median age of 36.5 years. The median ARAT time was 35 minutes, with a median circumference ablation of 300 degrees. Almost 13% of patients present some grade of stenosis that responded in all cases with endoscopic dilation, and our protocol was very strict because it included a clinical evaluation with a Jrelated quality of life questionnaire, 24-hour pH monitoring, upper endoscopy, and PPI-use evaluation, and they were followed up to 36 months after the procedure. At 3-month evaluation, we observed a decrease in the Mister score, acid exposure time, and health-related quality of life scores, with an improvement in heel upper valve grade to 1 in almost all cases, with a clinical success of 89% at this point, and that was maintained up to 72% after 36 months. Our multiple logistic regression model at 36 months after ARAT showed that 3 related factors were related to clinical success. They were 1 factor before procedure, that was the presence of heel type 2 upper valve grade, and 2 factors at 3 months after the evaluation, that were the presence of heel type 1 and acid exposure time less than 4.
The whole article is very interesting, but what are the conclusions that you obtained with these results regarding this new endoscopic anti-reflux ablation therapy?
I think that based on our results, we can conclude that this area is a feasible, safe, and effective therapy at early and mid-term evaluation for the treatment of GERD patients without sliding hiatal hernia. So we think that these results can be helpful in the evaluation of the role of this new alternative of treatment in the management of these patients. Thank you very much for watching this video, and we invite you to read our article in Gastrointestinal Endoscopy Journal.